I will talk today about the hypertension treatment targets in both the ACC and the European guidelines, as well as a comparison. This slide sums up both guidelines. It's from my book, the second edition of my book. Basically, in the American guidelines, the target blood pressure is less than 130/80 in all patients, and medications are initiated for a blood pressure of 130/80 or more in most cases, except the lowest risk profile patient, whose 10-year cardiovascular risk is less than 10% and where medications are initiated at a blood pressure over 140/90. The latter have still a blood pressure goal of less than 130/80, but you just wait to initiate medication until 140/90. Conversely, in the European guidelines, the target blood pressure is split according to age, not so much according to the risk profile. As such, the target blood pressure is less than 130/80 in patients less than 65 years, even if they don't have any CAD, diabetes, heart failure, and their risk profile is low. On the other hand, the target blood pressure is less than 140/80 in patients over the age of 65, even if they do have a very high risk profile, such as CAD, diabetes, heart failure, CKD, etc. For those patients, the ACC guidelines would recommend a blood pressure target of less than 130/80. The European guidelines have two interesting points I would like to comment on. One, the European targets are more focused on age than cardiovascular risk profile. Their idea is that younger patients are more likely to tolerate lower blood pressure. They have less U-curve, which I will explain in a little bit. They also have more longevity to benefit from this lower blood pressure. Even though their yearly absolute benefit is less than older patients and higher risk patients, they have more years to benefit from this lower blood pressure. A second interesting point of the European guidelines is that they recommend avoiding a reduction of systolic blood pressure to less than 120 and diastolic blood pressure less than 70 in all patients. Now beware, this is different from having a spontaneously low systolic blood pressure less than 120, which is actually considered an ideal blood pressure and is associated with the lowest rate of cardiovascular events as long as the patient is asymptomatic. The idea of a potential harm from blood pressure less than 120/70 is what is called U or J curve. Basically, as you reduce hypertension from high levels, mortality is reduced until a blood pressure of around 130/80. Then, if you keep reducing blood pressure, at some point, mortality will start rising. This point is what we call the J point, and is somewhere between 110 to 120 for systolic blood pressure. European guidelines use 120/70. I tend to use 110/65, which is a more pragmatic cutoff and provides me with a wider therapeutic range. The U-curve concept is explained by this very important curve that we call autoregulation curve. The tissue flow is basically maintained over and in spite of a wide range of blood pressure fluctuation via microcirculatory autoregulation. When the blood pressure declines beyond a certain point, tissue flow declines. The autoregulation curve is overwhelmed. This autoregulation curve and the J point vary according to the severity and the chronicity of hypertension and age. For example, this is the autoregulation curve of the hypertensive old patient. This is the autoregulation curve of a normal patient. All severely hypertentensive patients may have a J point of 120 millimeter of mercury for the systolic blood pressure, whereas a young patient with a flexible microcirculation and mild hypertension has a J point of 100 millimeter of mercury. This explains how young patients tolerate and potentially thrive with a lower blood pressure. Of note, even in hypertensive patients, autoregulation curve improves with time and hypertension and it improves with hypertension control so that patients can tolerate lower blood pressure with time. Their curve will shift a little leftward so they can tolerate a lower J point with time. Importantly, the only group where systolic blood pressure less than 120 does not preclude medications is the heavily afterload dependent systolic heart failure, where the J point is somewhere around 90 millimeter of mercury for systolic blood pressure. This is the relationship between stroke volume and afterload. Systolic heart failure is exquisitely sensitive to afterload, meaning you reduce afterload a little bit, you can dramatically increase stroke volume, so much that you make up for the reduction in blood pressure by increasing the cardiac output. This is not as much the case in normal ventricle, which does not increase its stroke volume by as much when you reduce the afterload. In fact, post-hoc analysis of carvedilol in Copernicus trial, candesartan in CHARM, valsartan in VALHAFT, and hydralazine nitrate in AHAFT have all shown that systolic heart failure continues to benefit from those drugs even at a systolic blood pressure as low as 90 millimeter of mercury. In fact, initiating those medications in patients whose baseline blood pressure was 90 to 100 millimeter of mercury tended to increase the blood pressure with time as heart failure and stroke volume improved with time. Now, I want to go back to the original idea of targets. And where does this target of 130 millimeter of mercury come from in the American and European guideline? The biggest driver of those guidelines is what we call the SPRINT trial, which randomized non-diabetic patients with hypertension and a somewhat higher risk profile to a target of less than 140 versus practically a target less than 130 millimeter of mercury. The lower target led to a reduction of total mortality, heart failure, and cardiac mortality. That reduction in mortality was small, 0.37% per year, which cumulates with time. And side effects such as syncope and acute kidney injury were increased in patients with the lower blood pressure target. Despite this relatively small absolute benefit, this is the trial that drove the guidelines targets. But that also explains why the European guidelines embrace that target in younger patients who are more likely to derive the additive cumulative benefit over time. Another important trial, a second one, is ACCORD trial of diabetic patients, which also compared an aggressive blood pressure control to a less aggressive blood pressure control less than 140. This trial was a trial of diabetic patients, and it did not show a benefit except for a reduction in stroke, but no benefit on mortality and other cardiovascular events. There are other trials. Again, none of them show the benefit of aggressive risk control except for the first one I showed, which is SPRINT trial. There are three major trials in CKD comparing aggressive versus less aggressive blood pressure control, meaning less than 140 versus less than 130. And AASK, MDRD, and RAIN-2 trials, they did not show an improvement in outcome with the more aggressive blood pressure levels. Same in diastolic heart failure and same in CAD. Indirect evidence does not really show mortality benefit with lower levels, but again, SPRINT trial is the largest and most dedicated trial for target assessment, and this is what drove the guidelines. I will move now to another important idea. When we say blood pressure of 130, 140, how do we define and obtain that number? Is it just the office number? The answer is no, it's not just the office number. Office number is not enough. Before we initiate therapy, all patients with a blood pressure in the mild to moderate range are to be screened for white coat effect, meaning patients with a blood pressure between 130 to 160 over 80 to 100, they are to be screened for white coat effect using home or ambulatory blood pressure monitoring with a goal blood pressure on those of less than 130 over 80. Studies have shown that ambulatory and home blood pressure monitoring is superior to the one measurement we obtain in clinic for the prediction of cardiovascular mortality. Therefore, in order to confirm hypertension diagnosis and to guide the drug titration on follow-up, ACC guidelines and ESC guidelines recommend the routine use of 24-hour home blood pressure monitoring or ambulatory blood pressure monitoring. And there is a large wealth of data supporting that. This phenomenon wherein the blood pressure is high in the office but normal at home, or at least much lower at home, is called the white coat effect. It is suspected in those patients who can barely tolerate any small dose of medication you give them and display frequently signs of overtreatment. This white coat effect increases with age as it is very much driven by the arterial stiffness, which aggravates blood pressure variability. Meaning when you have stiff arteries, the blood pressure shoots way up with any change in physiology, such as a change in sympathetic tone or a slight change in volume status. It also shoots quickly down with a reverse change in that physiology. So it is less prevalent in younger patients, even though younger patients may be more anxious, but they display less white coat effect. This white coat effect has a prevalence of 13 to 35% in hypertension, so it's highly prevalent, and it's even more so in the very old over 75, up to 50% or more. The important therapeutic idea here is that white coat effect has been associated with no or only slightly increased cardiovascular risk and mortality, and thus treatment is not recommended in neither ACC nor ESC guidelines, except possibly in patients with very severe white coat hypertension, over 160 over 100, and a very high cardiovascular risk profile. We may also see the reverse, and that's why, again, it's so important to check home blood pressure, regardless of whether the office blood pressure is controlled or not. So you can have a patient with controlled office blood pressure, yet a high home blood pressure. And this is what we call masked hypertension. This is even worse than white coat hypertension, because unlike white coat hypertension, masked hypertension is malignant, is associated with adverse long-term cardiovascular outcomes, and it needs to be treated. Both those concepts show you that home or ambulatory blood pressure is more important than office blood pressure and should be used to guide diagnosis, initiation of treatment, and uptitration or downtitration of treatment. Home blood pressure monitoring consists of self-measuring blood pressure every morning before medication intake and every evening. Unlike what some patients think, blood pressure should be measured before medication intake to ensure that those blood pressure medications are providing a sustained 24 hours control of the blood pressure without any wearing off of the effect. Now, ambulatory blood pressure monitoring consists of wearing a blood pressure cuff for 24 hours with automatic blood pressure measurements every 30 minutes, automatic initiated by the machine. While more prognostic data is available for the ambulatory blood pressure monitoring than home BP monitoring, a review of cohort studies addressing both modalities suggested a similar prediction of cardiovascular events, and one prospective study published in JACC this year showed superior correlation of home BP with LV mass. Now, here's the pragmatic management. You see a patient in the office, his blood pressure or her blood pressure is 130 to 159 over 80 to 99. For blood pressure in this range, you don't need to immediately initiate blood pressure medication. You need to do two things. One, initiate lifestyle modifications, especially diet, sodium control, exercise, and some degree of weight loss. And number two, monitor home blood pressure to again detect the white coat effect. Then bring the patient back to your office in 2 to 4 weeks and recheck the blood pressure and his home blood pressure log. If blood pressure is still elevated, particularly if his home blood pressure remains elevated despite some lifestyle modification, then drug therapy is initiated. And this is somewhat suggested by both the American guidelines and the European guidelines for this blood pressure range. Conversely, if the patient's blood pressure in the office is over 160 over 100 on two readings performed in the office, such as at the beginning of the visit, middle, and end of the visit, drug therapy is usually initiated immediately during that visit without awaiting lifestyle changes and home blood pressure monitoring. In general, not always. Sometimes you may wait for home blood pressure monitoring. Now, quickly, how and what to start. If blood pressure is 20 over 10 above the goal, which means usually it's over 150 over 90, a combination therapy is initiated. Otherwise, and especially in frail patients, dizzy patients, elderly patients, one medication may be initiated with a slow stepwise titration. There are three first-line drugs as established by the ALL-HAT trial: thiazides, ACE inhibitor or ARB, and calcium channel blockers. In the ALL-HAT trial, all three classes achieved similar reduction in mortality and MI. Thiazide diuretic, chlorthalidone specifically in that trial, was slightly superior. It was superior to ACE inhibitor for stroke prevention and slightly superior to ACE inhibitor and calcium channel blocker for heart failure prevention. Interestingly, it was even superior to ACE inhibitor for heart failure prevention. Conversely, as other trials have shown, beta blockers are less effective for hypertension control, for patient survival, and for stroke and MI risk reduction, and should not be used as first-line therapy unless there is a compelling indication, such as heart failure, angina, or arrhythmia. Regarding uptitration, if a patient's blood pressure is not controlled on a medium dose of one agent, it's best to add a second agent than to keep uptitrating the first agent. Let's say I have a patient who's taking lisinopril 20 milligram and his blood pressure is still uncontrolled. You achieve more blood pressure reduction by adding a calcium channel blocker or a thiazide diuretic than by going up on lisinopril to 40 or 80 milligram. You get more side effect with this lisinopril uptitration with limited further blood pressure control. A thiazide diuretic is typically added as a second agent for a couple of reasons. One, hypervolemia is a common mechanism of hypertension, which explains why thiazide is a very efficacious monotherapy, but it's also synergistic in combined therapy. And number two, hypervolemia is sometimes exacerbated by vasodilator-induced volume retention, which explains that synergistic effect of thiazide. Also keep in mind that patients with CKD, obese patients, and African American patients have high rates of hypervolemia. Obesity is associated with a significant activation of renin, angiotensin, aldosterone system, which causes excessive hypervolemia in obese patients, and therefore it explains their diuretic responsiveness. There is one trial I like to mention, the ACCOMPLISH trial. It suggested that when the combination therapy is needed, ACE and amlodipine was superior to the combination of ACE and hydrochlorothiazide in that trial. There are caveats though. That trial mainly recruited white patients without CKD and used hydrochlorothiazide rather than the better thiazide chlorthalidone. Therefore, that trial tells us that in white patients, a combination of ACE and calcium channel blocker is acceptable compared to a combination that includes a thiazide diuretic. At the very least, though, diuretic therapy should remain a third agent, if not a second agent. Now, if the combination of the three first-line agents has not achieved the target blood pressure, the next step is to do one of the following two things. Either add spironolactone or another potassium-sparing diuretic, or increase the dose of the hydrochlorothiazide or switch to chlorthalidone, the better thiazide. Basically, improve your diuretic regimen. That's the next step. It's been shown that small dose of spironolactone has a profound effect in drug-resistant hypertension and decreases blood pressure by 20/10 in resistant hypertension, according to Pathway 2 trial and ASCOT substudy. This is particularly true in obese patients whom, as I mentioned earlier, have significant activation of the renin-aldosterone system. Obese patients have a larger circulatory volume that they need to supply, and as such, they have activation of the renin-aldosterone system as well as the salt retention renal system. And therefore, they tend to have hypervolemia. They tend to be very responsive to diuretics, specifically spironolactone beside the thiazide diuretic. Of note, I sometimes start immediately, as soon as I start a thiazide diuretic, I start with it a potassium-sparing diuretic, such as triamterene, for two reasons. One, you get better blood pressure effect when you do that. That's one. And two, you improve the metabolic side effects of hydrochlorothiazide, such as hypokalemia or even hyperglycemia, based on some data. So a lot of time, I don't wait for resistant hypertension. I start automatically triamterene upon initiation of hydrochlorothiazide, and that's an acceptable strategy. Regardless, if you haven't done that up front, it's certainly time to do it once you reach the stage of resistant hypertension, despite the three first-line agents. Now, after all this, if the blood pressure is still refractory, then you start having a role for beta blockers, alpha blockers, and hydralazine. The catch is that beta blockers have an earlier role, of course, in patients with compelling indications such as heart failure or angina or arrhythmia. Now, I want to here elaborate quickly on the heart rate, the target heart rate. A tight rate control less than 70 beats per minute has proven beneficial in chronic heart failure with reduced EF. But unlike what a lot of physicians think, it has not shown benefit in stable CAD, in angina, in hypertension in general, in heart failure with preserved EF, diastolic heart failure, or in atrial fibrillation, even atrial fibrillation with heart failure and reduced EF. I further explain those concepts in a separate talk of target heart rate, which I suggest you review as well. Thank you for listening, and I hope this was useful.